Today we are going to discuss pulmonary graphics. So the respiratory mechanics, as we know, can be monitored by measured parameters like pressure, flow, and volume, and also through calculated parameters like compliance and airway resistance. The pulmonary graphics can be broadly divided into two types of graphics. Firstly, scalars, which can be flow time scalar like this, which has got a positive as well as negative deflection, pressure time scalar, and volume time scalar. And both pressure and volume time scalar have got only positive deflection above the x-axis. Then we have loops, which can be a pressure volume loop like this, or a flow volume loop, which has got a peak end expiratory flow, peak inspiratory flow, and a functional residual capacity. In different ventilators, we can have a different configuration. So in some ventilators, the inspiration can be above and expiration can be below. During spontaneous breathing, we have a clockwise type of configuration of a pressure volume loop. So there will be a negative as well as positive deflection like this during spontaneous breathing. But when there is a positive pressure ventilation like CPAP, BiPAP, or after intubation, you have all the wave belonging to the right side of the y-axis, everything on the right side. There is no negative deflection. So depending upon the mode, there will be variations. During pressure control mode, you will have a pressure time scaler looking like this with a flat top. But in volume control mode, you will have a pressure two peaks, that is PIP and P plateau. Next slides will go more deep into it. In flow time scaler, you will have a decelerating flow in pressure control mode, and in volume control mode, you will have a constant flow. And in pressure control mode and volume control mode, the volume time scaler almost looks like same. So going into the pressure time scaler, in pressure control mode, as I said, pressure does not change throughout the inspiration. That's why it is a flat top. And that is why we only call it as a PIP. So there is only peak inspiratory flow during pressure control mode. Volume control mode has or changing pressure during inspiration because it's a volume control. So volume is fixed, but pressure changes. So you have two pressures, peak inspiratory flow, a peak inspiratory pressure, that is PIP, and plateau pressure. There are two different pressures. So if you see in actual patient, we can see that there is a PIP and P plateau, and this is a volume control mode. And here we can see there is a flat top. So this is a pressure control mode. So this is how the pressure time and the pressure time scalar looks in volume control and pressure control mode. This is one more example of volume control mode where we have a PIP and P plateau in pressure time scalar. So in mechanical ventilation, in the pressure volume loop, in pressure control mode is box shape like this, while the pressure volume loop in volume control mode is fusiform or sigmoid shape like this. Why? Because in pressure control mode, the pressure is fixed. So within few milliseconds of inspiration, the set pressure is reached. And then in the remaining part of inspiration, same pressure is maintained throughout the inspiration. And then the expiration starts. That's why it is a box shaped morphology in pressure control mode. While in volume control mode, you will see the pressure is changing throughout the inspiration. That's why you see a sigmoid shape. So when we look at the actual patient, so in actual patient, the patient is on pressure control mode, and you can see there is a box-shaped morphology in pressure control mode. And when we change the mode to volume control, same patient, you will see that the morphology is changing and it has become a sigmoid shape. So you can see the difference of pressure volume loop in pressure control and volume control mode. Coming to loops, this is a loop of volume control mode because as we discussed already, in volume control mode, there is a constant flow. The flow is constant. It remains constant throughout the inspiration. That is why it is a flat at the top. The expiration in both pressure control and volume control has a decelerating flow. So it will remain the same. But in volume control mode, the inspiration will have a flat top, while in pressure control mode, you will see a decelerating flow during inspiration and also decelerating flow during expiration. So this is how you differentiate the the flow volume loop between pressure control and volume control mode. Now coming back to the pressure time scalar, as we discussed, there is a PIP and P plateau, and the difference between PIP and P plateau tells us about airway resistance. and the plateau pressure is basically giving an impression about the alveolar pressure. And PIP is determined by the airway resistance, as we discussed. The difference between P plateau and PEEP, or positive index of pressure, is nothing but driving pressure. So this is how it is, and plateau pressure usually represents alveolar pressure, particularly when there is a normal chest wall elastance. So this is a normal pressure time scalar with a PIP and P plateau. When there is an increased airway resistance, the PIP will be higher, but P plateau will remain the same. So this is a sign of increased airway resistance. So you can see the plateau pressure is same, but airway resistance is high, so PIP is high. And when there is a poor compliance like pulmonary edema or ARDS, you will see the difference between PIP, P plateau will not be much, but P plateau is higher than rest of the things. So this is a sign of poor compliance, and the middle one is increased airway resistance. So you can look at the morphology of pressure time scalar and decide about the clinical situation. So in this particular graph, we will see, I will pause this video here, and in this video, I will pause here, and now we can see both the places. Here 37 is the peak pressure, and here also we have a 38 peak pressure, which is very high. But here we can see the PIP and P plateau gap is high, and here we can see the gap between PIP and P plateau is not very high. So this means these high pressures are mainly because of increased airway resistance, and here the high pressures are mainly because of poor compliance. Both are on volume control mode. That's why we have PIP, P plateau, and we can see the volume. We can see the flow time scalar also with constant flow in both. So basically, volume control mode, increased distance between PIP, P plateau suggestive of airway resistance, and very little difference between PIP, P plateau suggestive of poor compliance. So in VC mode, plateau pressure is measured by an inspiratory hold of around 2 to 3 seconds. So we can measure the plateau pressure. In PC mode, it's very important that inspiratory time should be sufficiently long, and it is important because there is a decelerating flow in pressure control mode. If inspiratory time is not sufficiently long, then the tidal volume will not be delivered completely, and then you will not get a proper zero float state. So first you have to make sure that your inspiratory time is sufficiently long, complete inspiratory flow is touching the baseline, and only then you will apply inspiratory hold to measure the plateau pressure. So in this particular example, you can see the flow time scalar is touching the baseline, and then the expiration is starting. And when we applied inspiratory hold, this is in pressure control mode, you can see the P peak, that is PIP, is almost equal to P plateau. This is P plateau 19. Here also you can see P plateau. So PIP and P plateau are almost same as long as the decelerating flow is touching the baseline and you're allowing complete tidal volume delivery and making sure you have a good pause time. But suppose if you have a situation where your inspiratory time is not sufficiently long, your flow is not touching the baseline, and you are entering into expiration, and in this situation, if you are applying an inspiratory hold, then you will see there is a significant difference between PIP and P plateau. Plateau pressure is shown as 17 and P peak is actually 20. So there will be discrepancy. That's why you need to apply inspiratory hold ideally to check the plateau pressure, or make sure that your inspiratory time is sufficiently long so that decelerating flow touches the baseline and then expiration starts. Coming to patient triggering, when you have a negative deflection like this means your patient is triggering. This is a triggered patient triggered breathe, or patient is triggering by pressure triggering or flow triggering. In flow pressure volume loop also, you will see this type of negative deflection. This is a suggestive of patient triggering. So there are two main types of triggering: flow triggering versus pressure triggering. Both commonly used ventilators like GE and Mackay ventilators have both the types of triggering mechanisms. So in GE, you can rotate the knob in one side and you will get flow triggering, and the same knob, when you rotate on the other side, you will get flow triggering. So this is Mackay. You rotate on one side, you are getting pressure trigger, and the same knob, when you rotate on the other side, you get flow triggering. And in GE also the same thing, you rotate on one side, you get flow triggering, and when you rotate it on the other side, you get pressure triggering. In Mackay ventilator, during flow triggering, the lower number indicates higher trigger setting. This means 2 liter will be a higher trigger than 6 liters per minute. Now, the pressure triggering means the ventilator is set to detect a certain change in the pressure, and the ventilator will be triggered whenever the airway pressure drops by that set amount. So, for example, if you have a set PEEP of 5, and you have a pressure trigger sensitivity set at -2, then a breathe is triggered whenever the airway pressure falls below 2 centimeters of water, that is, falls down to 3 centimeters of water. So we can imagine that if there is a problem of like asthma, with there is a significant air trapping because of bronchospasm, mucosal edema, and airway narrowing, and there is an intrinsic PEEP and there is auto PEEP, then the triggering will become more difficult, because then the patient will have to work against that auto PEEP to trigger the next breath, and that will lead to problems of delayed triggering or ineffective triggering. So suppose you have a airway narrowing leading to an auto PEEP of 10, then in this particular instance, if you don't apply any PEEP from outside, zero PEEP, then the patient has to apply a negative pressure of 11 centimeters of water to draw the breath inside. But if you apply a extrinsic PEEP of say 7, and there is an intrinsic PEEP of 10, now the patient will have to, the gap is 10 minus 7, 3. The patient will have to take around at least 4 centimeters of trigger to trigger the next breath. So that is the advantage of applying some PEEP from outside, to make it easy for the patient to trigger the next breath during pressure triggering type of system in patients with increased airway resistance and auto PEEP or intrinsic PEEP. In pressure triggering, one more problem is whenever the patient is dropping the pressure to trigger, there is a drop in the mean airway pressure also. The drop may be just 1 to 2 centimeters of water, but it may matter in situations of poor lung compliance or severe ARDS. Flow triggering was designed to avoid these two issues. The first issue, which we discussed, where the patient has to generate negative airway pressure to trigger the next breath, and the second thing is drop in the mean airway pressure. So in flow triggering, what's happening is there is a continuous flow of gas which is sent through the ventilator circuit. In Mackie, usually this bias flow is around 2 liters, while in GE it is around 2 to 8 liters per minute. And when the patient makes an inspiratory effort, some of the gas that was previously flowing continuously through the circuit is diverted towards the patient. And this the ventilator will sense and take it as a flow triggering and trigger the next breath. But the problem with the flow triggering is that automatic triggering sometimes may result from leaks in the ventilatory circuits. So there is no clear consensus whether pressure triggering is better or flow triggering is better. They have their own pluses and minuses. On one hand, the pressure triggering, there is a drop in the airway pressure and there is a difficulty in triggering the breath, particularly in presence of auto PEEP, which the flow triggering does not have these issues. But in flow triggering, there is always a problem of triggering in presence of air leaks. But water in the circuit can trigger auto triggering in both pressure and flow triggering systems. This is an example of flow starvation, and this will be seen only in volume control mode, because in pressure control mode like pressure control mode and PRVC mode, where there is decelerating or variable flow, whenever the patient is breathing with a requirement of extra flow will be provided. But in volume control mode, there is a fixed flow delivery. So if the patient requires more flow, extra flow will not be delivered, and there will be scooping of the pressure time scalar like this. This is a sign of flow starvation. So this is an example of flow starvation, as we can see here. And in the pressure volume loop also, you can see there is a scooping. This is a sign of flow starvation. And as I said, you can see this in volume control mode. So this was a big child, actually around 35-40 kilo, and we can see the flow was just 14 liters. So we just increased the flow a little bit, and when we increase the flow to 25 liters per minute, the same patient, we can see live that the scooping disappeared and the flow was better now. So we can troubleshoot the problems by looking at the pulmonary graphic. The scooping got corrected as soon as we corrected we increased the flow. So the flow starvation can be corrected by increasing the flow, or you can simply change the patient from volume control mode to pressure control mode of ventilation, or regulated volume control mode of ventilation. Coming to flow time scalar, we have two types of flow time scalar. The pressure control mode and volume control mode has different morphologies. pressure control mode has a decelerating flow. Volume control mode has this kind of constant flow. So we can see in these two modes, this is the volume control mode, you have a flat top, and this is a pressure control mode. We can see decelerating flow in pressure control mode. So in the flow time scalar, this is the initiation of flow, this is peak flow, and then we get a constant flow, cessation of flow, followed by a period of no flow. This is also called as pause time. It should be sufficiently set. So, and then we have beginning of expiration. When the expiration valve opens, this is our peak expiratory flow. This is our inspiratory time, and this is our total cycle time. Similarly, during expiration, we have beginning of expiration, then peak expiratory flow, then end of expiratory flow. So this is our duration of expiratory time, and this is total available time. When we look at this particular flow time scalar, we can notice that the inspiratory flow is not reaching the baseline and expiration has begun. This can be because of two reasons. One is insufficient inspiratory time. That is why the expiration time starts before inspiration ends. And second possibility is flow cycling. This is a situation where the expiratory flow is not reaching the baseline and inspiration has started. And in this particular case, the reason is insufficient expiratory time. Now, how to set appropriate inspiratory time? So we'll discuss the concept of time constant. Time constant is the time which takes the alveoli to equilibrate with the atmosphere. It takes one time constant for 63% and two time constant for 86% and three time constants for 95% of the alveoli to equilibrate. So generally we set high time of at least three time constants. Ideally, five time constants will be required for complete equilibration. So we need to understand that airways are always expanding during inspiration, and during expiration they are narrowing. So if there is a problem of bronchospasm or increased airway resistance, there will be more airway resistance during expiration compared to during inspiration. And this discrepancy is important to for formation of problems like autopsy. We know the time constant, which is a product of compliance and resistance, and hence time we can see that if there is an increased airway resistance, then you will require longer time constant. And when there is a poor compliance like ARDS pulmonary edema, you need actually short time constant. That we need to understand. So when there is a increased inspiratory resistance, you need longer inspiratory time. When there is expiratory airway resistance, you need longer expiratory time. And most of the patients with increased airway resistance will have more problem of resistance during expiration, as we discussed. So usually the patients will require longer expiratory times for problems of increased airway resistance like asthma or bronchiolitis. While in patients with poor compliance, you can manage with shorter time constant, because in shorter time constant also airway equilibration will happen. But of course, it can happen is different thing. But for oxygenation, you want to maintain a positive pressure over a longer inspiratory time. Some people keep a longer I time for better oxygenation, for better mean airway pressure across the inspiration. That is different thing. But the airway equilibration or time constant requirement is shorter for patients with poor compliance. So this is a normal lungs requirement. This is a poor compliance. So as I said, the short time constant requirement, and this is increased airway resistance where you require longer time constant. I will repeat once again. The poor time. This does not mean that in ARDS we should ventilate with shorter I time. Actually, you can ventilate with shorter I time. That is what I'm trying to say. But normally we keep longer items so that we keep the alveoli recruited throughout the inspiration. So increasing the time, inspiratory time may improve tidal volume delivery during inspiration, and increasing the expiratory time may improve the removal of tidal volume during expiration in patients with increased airway resistance, while increasing the I time won't affect the delivery of tidal volume in those with poor lung compliances, because their tidal volume is mostly delivered in the initial phase of inspiration due to short time constant. So what we are trying to say here is, in ARDS, even with shorter time constant, tidal delivery will complete. But for maintenance of airway pressure, for that better alveolar recruitment during inspiration and oxygenation, to improve. You want to keep a longer item, that is fine. But that is not for tidal volume delivery. Tidal volume delivery will take place in shorter item also. Now, in this particular scenario, we can see that the flow is not touching the baseline and expiration is starting. So we need to see what is our I time. So when we look at the I time, we can see here it is set at 0.44. When look at the patient, the child is little bigger, and this 0.4 is for neonates, very small I time. So we increase the I times to 0.5, 0.6 seconds here, and then you see what's happening. So we can see very clear difference. As soon as we increase the I time, you can see now the inspiration is touching the baseline. We get a clear pause time, and then expiration is starting. And previously, because of shorter I time, this was not happening. The inspiration was not touching the baseline and expiration was starting. So this is one advantage of looking at the flow time scalar and adjusting inspiratory time appropriately. So if you can't remember all this complex, if you think this time constant thing is very complex, or you can't remember how much exactly inspiratory time you should select at what age, then this is the best strategy. Just look at the flow time scalar and keep your items such that your inspiratory flow is touching the baseline, and then there is a small flat part, and then your expiration starts, so that you are allowing good inspiration, tidal volume delivery, and then expiration is starting. And at the same time, make sure that inspiration is shorter than expiration. So this is how you can set. Now, what to do with situations of increased airway resistance? So when there is increased airway resistance, the flow will not reach the baseline. So this is because of the air trapping. We had also seen earlier flow was not reaching the baseline during expiration, but at that time the inspiratory time was insufficient. In this case, you can see the inspiratory time is more than sufficient. It's quite prolonged, but in spite of that, the expiratory flow is not reaching the baseline. So this is because of increased airway resistance leading to flow not reaching the baseline. So in this particular scenario, we can see here that the expiratory flow is not reaching the baseline. So that we need to see, and we have to see the flow volume loop also. In the flow volume loop, this is a normal flow volume loop where this is a volume control mode. As we can see, it is flat top, and this is normal flow volume loop. And during bronchospasm, it will become like a bun because the flows are reduced, and particularly during expiration, it is more significantly reduced compared to inspiration, and we can see the flow is not touching the baseline. This is again because of air trapping. And when we start nebulizations like Livolin nebulization, bronchodilator therapy, basically max self infusion, something like that, then we see the flows are better now, and the flows are touching the baseline. Also, the air trapping is reduced. So you can watch the flow volume loops to see the response to your treatment. Now, looking at the flow time scalar in bronchospasm during expiration, the height of the expiratory flow is reduced because of bronchospasm. And when you give bronchodilator therapy, you will see there is significant improvement of flow during the expiration. So how to measure the auto PEEP? When there is a pressure time scalar, when you apply a expiratory hold, you will see a PEEP which is above the set PEEP, and this extra PEEP above the set PEEP is called auto PEEP or intrinsic PEEP. So in this particular scenario, you can see the set PEEP is 8 centimeters of water, and then we are going to apply an expiratory hold of around 4 to 5 seconds. And when you apply an expiratory hold, this was the set PEEP as we showed already, 8, and you can see here the PEEP now is shown as 12 or 12, around 12 or 13. So even if we take it as 12, so the set PEEP was 8, and after expiratory hold, the PEEP shown is 12. So that means 12 minus 8, that is 4, is the intrinsic PEEP. The set PEEP is 8, that is PEEP E, and intrinsic PEEP, that is PEEP I, is 4, and PEEP total is 12. So this is how you calculate your expiratory hold. So this is a patient with increased airway resistance. As you can see here, there is a increase in the distance between PIP and pupillar tube. You can see the expiratory flow is much less compared to inspiratory flow. You can see in the pressure volume loop, there is a pressure over distension peaking, and you can see this is a pressure over distension peaking. You can see in the flow volume loop, the expiratory flow is so small and inspiratory flow is good. So reduce expiratory flow in the flow volume loop, reduced expiratory flow in flow time scalar, pressure over distension peaking in the pressure volume loop, big difference between PIP and P plateau. And you can here, you can see insufficient or insufficient triggering also, inadequate triggering also. This is also again because patient is on pressure triggering mode and not able to trigger because of auto tip. So all these are classical features of increased airway resistance. And after good bronchodilator therapy, the things have changed. And actually, the patient is shifted to pressure control mode also. So you can see the decelerating flow. But you can see after bronchodilator therapy, the flow has definitely improved during expiration in the flow volume loop as well as during the flow time scalar. So you can use the pulmonary graphics to assess the response to your treatment. And here also, you can see the expiratory flow is not reaching the baseline. Expiratory flow is not reaching the baseline. Respiratory rate was 50, and the inspiratory time was 0.6. So what we did was we are just reducing the rate and increasing the expiratory time. And just by increasing the expiratory time, we can see that the flow is now reaching the baseline nicely. So in this case, what we have done is we just increase the expiratory time by reducing the rate and shortening the inspiratory time and increasing the expiratory time and solving the problem of air trapping. So PC and VC mode, we saw in pressure control mode, there is a box shaped morphology because in pressure control mode, what happens is most of the flow, maximum flow happens in the first few milliseconds of the inspiration, and maximum pressure is also reached within first milliseconds, few milliseconds of the inspiration. And because of that, there will be maximum airway resistance also because of highest flow in the first few milliseconds of inspiration. And then there will be the same pressure maintained throughout the inspiration, and there is a decelerating flow after that, and then there is a expiration. This happens in pressure control mode. And as we can see here, this all the volume takes long time to deliver. So this in PC control mode or pressure control mode, we can see the amount of tidal volume delivery will depend upon the available time during inspiration, and hence will lead little longer inspiratory time compared to volume control mode for delivery of tidal volume. So during pressure control mode, due to decelerating flow, we need a longer I time. And of course, as we saw already, we need longer expiratory time because expiratory resistance is higher and we need longer time constant during expiration. So in pressure control mode, you need both longer inspiratory time as well as longer expiratory time to ventilate patients with increased airway resistance. But in volume control mode, it's a constant flow, and the right at the beginning of the inspiration, the entire flow is delivered, and then the pressure inside the lung just builds up and expands the volume over a period of time, and the pressure is changing. So that is why even with a shorter inspiratory time, all the volume will be delivered in volume control mode. And during the situation of increased airway resistance in volume control mode, you can keep shorter I time without worrying and keep a longer expiratory time, which in pressure control is usually difficult because in pressure control you have to keep I time also sufficiently long for decelerative flow to touch the baseline, and expiratory time also should be long. So it is little difficult. While in volume control mode, you have more liberty. You can keep much shorter inspiratory time without worrying because all tidal volume will be delivered. Of course, you can't keep very short I time also, but you can keep considerably shorter I time in volume control compared to pressure control, and liberal long expiratory time with low respiratory rate as is required in patients with increased airway resistance. Coming to assessment of compliance, this is a normal pressure volume loop with this kind of morphology. And when there is reduced compliance, then it is going to bend like this towards the x-axis. So in volume control mode, you will see the hysteresis is also less because of poor compliance. It will be little narrower, slimmer type of pressure volume loop bending towards the x-axis. And as the compliance is improving, you will see the pressures also reducing, and the hysteresis also improving, and the angle also becoming away and away from the x-axis. So better hysteresis and lesser pre-plateau pressures and PIPs is a sign of improving compliance in volume control mode. While in pressure control mode, this is going to be the morphology of pressure volume loop with the lower tidal volume because of poor compliance, and the PIP will be fixed. So pressure will not change, but as the compliance improves, you will see the volume will go on improving with improving compliance. So the question is, the pressure in the breathing system in pressure control mode is constant after reaching the PIP, as we saw already, and this box shape morphology is reached. So um, can we draw a conclusion about lung compliance in this kind of pressure volume loop? Some people say that pressure control mode cannot be used to comment about the lung compliance, which may not be entirely true, because first thing is, as the compliance is improving, even in pressure control mode, you will see there is improvement in the volume. And second thing, the pressure volume loop in pressure control mode will be like this. So you will have this point A, and you will have point A will be the peep. In this particular graph, it is 0, but it will be some set peep of 5 or 6 or 10. And you will have a point B also. So in pressure control mode, the slope of this particular line will be an indicator of the compliance. So when the slope is going towards more of x-axis, it is a poor compliance basically. So this can be used to judge the compliance of the lung. And for this is when there is an inspiratory resistance, you will see a bulging on the inspiratory side, and when there is expiratory resistance, you will see bulging on the expiratory side. So when we look at the patient here, we can see that there is a bending towards the x-axis plus bulging on the right side, inspiratory side as well as expiratory side, the sign of poor compliance. And this is the situation where there is only increased resistance during inspiration and not much resistance during expiration. It is a kind of a dynamic airway resistance. For example, patients with tracheomalacia, and in this particular example, the PEEP is only 0. So when you apply an appropriate PEEP, and this PEEP, suppose a PEEP of say 5 or 10, 5 or 6, see, this positive and expiratory pressure will splint the airway and reduce the collapse of the airway during inspiration, will solve the problem of increased airway resistance during inspiration. This is an example of pressure over distension leaking, and this is again going to be seen in both the situations of increased airway resistance as well as poor lung compliance, as we saw earlier. This is a pressure over distension leaking. And air leak will be seen like this when the flow is not reaching the baseline in the x-axis. We have seen earlier the flow was not reaching to the baseline, and it was ending on the y-axis. So that was because of air trapping. When it is ending on the x-axis, it is because of air leak. In pressure volume loop, you will see something like this. This is also because of air leak. So when you look at the actual patient, you will see that, see, there's an empty gap between there's a gap here. So this means there is an air leak. Same thing you will see in the volume time scalar also. Here there is a gap, and you will see the difference also between inspiratory tidal volume and expiratory tidal volume. So all these signs are signs of increased airway. There's a signs of air leaking. So big difference between inspiratory volume and expiratory volume. The volume time scalar not reaching the baseline, and the pressure volume and flow volume loops not reaching the baseline. When there are secretions or water trapping in the ventilator circuits, you will see this kind of uh, morphology. So this is the auto triggering, and as we already discussed, the both pressure triggering as well as flow triggering systems will have this problem when there is a water in the circuit, and you will see this kind of problem because out of auto triggering because of water in the circuit. So as you can see here, there is so much of water condensation, and this problem is solved in the same patient as soon as we removed all the water from the circuit in the same patient. So as you see, we remove the water condensation, problem is solved. So we can use pulmonary graphics to diagnose so many problems, to assess the response to treatment, and to troubleshoot so many issues. So we have seen that pulmonary graphics are useful in mechanically ventilated patients to assess various important lung dynamics, and they provide insight into pathophysiology of the lungs. And as we can see from this picture, the patient is lying here, but nobody is watching the patient. Everybody is busy with the different gadgets. This should not happen. We should look at the patient also. So we should not be just watching the pulmonary graphics, but we should also watch what is the patient doing to illustrate this particular thing. I will show this particular situation. In this situation, this child is on a ventilator with this type of gasping type of breathing, and this ventilator endotracheal tube is connected to a EtCO2 module, and there is a nebulization chamber attached, and child is breathing like this. And we can see, when we look at the ventilator side, we can see a double triggering, and we can see some insufficient triggering in between. And when we shifted this patient on volume control mode, then we can see a lot of flow starvation. See on volume control mode, you can see a lot of flow starvation going on because child is so having gasping type of breathing. So what we did, I'm showing live, actually, nothing I edited here. We just removed the EtCO2 module, we removed the nebulization chamber, and we just gave a small dose of ketamine, just light sedation, and removed this particular assembly of EtCO2 module and nebulization chamber, which was creating so much of dead space, leading to flow starvation, double triggering, insufficient triggering, all types of patient ventilator asynchrony. And then we look at the patient now and see the patient is comfortable, breathing comfortably, and all asynchrony removed, and all the graphs are good now on PRVC, and the patient is absolutely comfortable. So this is what I'm trying to say in this. It's so important to understand pulmonary graphics. Although we have not yet discussed patient ventilator asynchrony, in some other lecture, we will discuss patient ventilator asynchrony also to understand further the usefulness of pulmonary graphics. Thank you very much.